Thank you for joining Cancer Support Community Atlanta for this four-part physician-led education series, A Focus on Cancer in the African American Community. This program focuses on prostate cancer and is facilitated by Dr. Ronald Anglade with Georgia Urology. If this is your first time participating in a Cancer Support Community Atlanta program, we invite you to visit our website and complete a new attendee form to stay connected to all future programs. Welcome everyone to the third installment of the four-part series of Focus on Cancer in the African American Community, with today's program focusing on prostate cancer. I'm Katie Armsby, the Program Outreach Director with Cancer Support Community Atlanta. Cancer Support Community Atlanta continues to offer free support programs virtually to those affected by cancer, which includes a prostate cancer support group. This group meets virtually monthly and is facilitated by a licensed mental health professional. We invite you to visit Cancer Support Community Atlanta's website, cscatlanta.org, where you can find a complete schedule of the virtual events available. You can also register for the remaining program in this series, which will take place next week, at our website. Again, that's cscatlanta.org. As a reminder, everyone will remain muted for the duration of the program. We invite you to enter questions into the program chat box, which will be addressed during the Q&A at the end of the program, time permitting. I want to welcome back our program moderator, Dr. Rylan Gore with North Atlanta Breast Care. Dr. Gore has been moderating this series and will be facilitating the October 9th presentation of Focus on Breast Cancer in the African American Community. Dr. Rylan Gore is a board-certified fellowship-trained surgeon in breast surgical oncology and specializes in the diagnosis and surgical treatment of benign and cancerous breast cancers, as well as all breast-related disorders. Dr. Gore is a highly trained physician skilled in advanced breast surgery procedures and minimally invasive techniques. She practices with North Atlanta Breast Care and has served in community outreach programs as an advocate to help spread breast cancer awareness. So with that, welcome back, Dr. Gore, and I will go ahead and pass it off to you to introduce today's presenter.
Thank you for everybody that's been joining us every week. We appreciate your commitment to our series on a focus on cancer in the African American community. I'm super excited today to introduce Dr. Anglade, who will be talking to us today about prostate cancer in the African American community. Dr. Ronald Anglade received his undergraduate degree from Brown University and completed his residency in surgery and urology at the Boston University School of Medicine. Dr. Anglade is a member of the American Urological Association, the Society for the Study of Male Reproduction, and the American Society for Reproductive Medicine, and the Society for Male Reproduction and Urology. Dr. Anglade currently practices at Georgia Urology. His research interests include genetic causes of male infertility, penile implants, and treatment options for erectile dysfunction. Without further ado, I introduce to you all Dr. Ronald Anglade. The floor is yours, sir.
All right. Well, Ron, thank you so much for that gracious introduction. It is an absolute honor and privilege to participate in this series of events. And I want to thank you specifically, but also the cancer support community at Northside Hospital Cancer Institute. And as the third speaker in this series, I know I have a tough act to follow. I watched the discussions held by Dr. Glasgow and Dr. Mullins, who discussed GYN malignancies as well as colorectal malignancies, and they had multiple topics to cover in their discussions. I'm lucky that I only have to discuss prostate cancer, but prostate cancer is obviously a disease that affects many, many men, particularly men of color. Specifically, I want to mention that we've just got through our Prostate Cancer Awareness Month, the month of September. Annually, we like to do programs and discuss prostate cancer, so that was a great month for us. And we are going to soon be entering our Movember month, and that's a month where you might find a lot of guys who, like myself, are generally clean-shaven, will start growing beards or mustaches, and those are done in order to sort of support men's health issues. But with all that being said, again, thank you for having me, and hopefully we'll have a great conversation this afternoon on a glorious Friday. So first, I'd like to start talking about what we'll cover today. Prostate cancer in general is a huge topic, so we'll try to get into some of the definitions about prostate cancer, specifically what is our prostate gland, what is prostate cancer, what is cancer in general, and we'll cite some statistics regarding prostate cancer. And then we'll talk about what you might look for someone who has prostate cancer, is developing a prostate malignancy. We'll talk about how prostate cancer is graded and staged, and how we will treat it based on those findings. So again, this conversation that I like to say, not a lecture, but we'll have a conversation about the disease, the disease state, and what men should look out for as they go through their process or journey if they happen to be afflicted by this disease. Okay, so first of all, what is our prostate gland? So for men, obviously men are only the ones who have a prostate gland. It's a small gland that sits below the bladder, between the bladder and the urethra. And the prostate gland's major function is to produce fluid that helps to support sperm, okay, and forms most of our ejaculate. So as the sperm become combined with the ejaculate, we provide nourishment. So when a man ejaculates, the sperm are nourished as they make their travels for procreation. So in this slide, you'll see the anatomy of the prostate gland, where it sits in the male pelvis, as well as what can be a tumor if you develop the prostate cancer. So briefly, what is prostate cancer? And I won't per se read from these slides, you can read them as well. But in general, prostate cancer is a cancer that one would expect begins in the prostate, and as prostate cancer progresses, it can leave the prostate. It can end up in some of the structures that surround the prostate, or that would be considered sort of a locally advanced disease. Or in many instances, it can spread throughout the body, and in those situations, that's when the disease becomes a lot more significant. Although if it is locally confined, we'll talk about this in more depth later, even if it's outside of the prostate gland, many of those tumors can be treated and cured. So when we talk about a lump in the prostate, and this will speak, and I'll speak to that as far as a prostate exam is needed, it doesn't always have to be cancer. There can be benign lumps of the prostate, and we can discuss that as well. And when we talk about prostate cancers, not all prostate cancers are deadly. Some prostate cancers can be lived with, and many men die with prostate cancer and not from it. So when we talk about our prostate cancer statistics, we see that for the top 10 cancers in men, as of 2017, prostate cancer was the most commonly diagnosed prostate cancer in men. I'm sorry, most diagnosed cancer in men. And when we talk about death rates from cancer, we see that prostate cancer is just behind lung and bronchial cancer. Now, those statistics are changing, and they're changing fairly rapidly, because as more and more people quit smoking, are not using tobacco products, lung cancers are decreasing, and prostate cancer statistics are essentially staying the same. Now, the good thing that we'll talk about when we discuss prostate cancer is, in general, when men are diagnosed with prostate cancer, the survival rate at 5 years is actually quite good along all races. So in the slide over here to the left of the screen, you'll see that most men will do well with their prostate cancer. However, when we talk about men of color, we see that prostate cancer and death from prostate cancer doubles over almost every other racial and ethnic group. So when we talk about prostate cancer statistics in men of color, we see that men of color are diagnosed with prostate cancer at all age groups, as early as in their 40s to, as late as in their 70s or 80s. And in this last line, we talk about prostate cancer in African American men being 1 in 5, whereas in the general population, the statistic is more about 1 in 7. And when we talk about prostate cancer, we'll see that it is the second leading cause of cancer death in African American men over the age of 45. So heart disease is the #1 killer, and that's pretty common and I think well known. But when we talk about lung cancer, stroke, prostate cancer, the second leading cause of cancer death. So researchers have spent a lot of time trying to figure out why African American men and women are at higher risk for being diagnosed from and dying from their cancer diseases. And the factors are it's a multifactorial issue. There's not just a genetic issue. It's not access to care issues. It's not just one issue, but it's a complex interaction of many issues, which include access to health care, access to physicians, access to healthy foods, lifestyle issues. So as we go through looking at why we as people of color don't do as well when faced with these diseases, it's a complex question and equation that we have to answer. One thing that I want to bring up, particularly given this current COVID epidemic, is that we can see that physicians in general and researchers are trying to encourage African Americans to be involved in some of the new trials and the vaccine trials and so forth, because we find that African Americans generally don't get involved in some of the newer studies, and that may lead to some of the reasons why we cannot have treatments that are tailored to us. So a couple of facts about prostate cancer, and these are not just for African Americans, but for men in general. About 3 million men in the United States live with their prostate cancer. They've survived prostate cancer. They've either been cured of the disease or they're living with the disease. That we should screen men generally between the ages of 55 and 69. That recommendation can change based on risk factors. We can see that some men are at higher risk for prostate cancer and should talk to their doctors about being screened earlier. And those are men of color or those who have a first-degree relative who have had the disease or been treated for the disease. And in many instances, early detection is key, because once you can find the cancer early, make recommendations as to treatment or observation, it does not have to be a deadly disease. And we'll talk a little bit more about the PSA in just a little while. So what are the symptoms of prostate cancer? And this is a question I get asked a lot. You know, you have a man come in and say, how do I know I have prostate cancer? What are the symptoms? And in general, there are really not any early warning signs or symptoms for prostate cancer specifically. So men will come in and say, doctor, I'm getting up at night and my stream is slow, I'm peeing too much, I'm incontinent, do I have prostate cancer? Or even I see blood in my ejaculate, does that mean I have prostate cancer? And in many instances, it does not at all. So what I like to explain to men when I have conversations such as these are that don't be afraid if you develop those symptoms. It doesn't mean that you have cancer and that you should be afraid to come in and see your urologist or your physician, because in many instances, those symptoms are things we can treat, such as prostatitis, which is a prostate infection. It can be BPH, just a benign growth of the prostate. It can be even just a prostate injury that can be addressed. So if you have these symptoms, blood in the urine, blood in the semen, pain when urinating, don't ignore them, and those are symptoms that should be evaluated. And in some instances, they may lead to a diagnosis of cancer, but in the vast majority, it doesn't. Now, I briefly mentioned the PSA, or the blood test called PSA, and that is actually very important whenever we discuss prostate cancer. It's a topic that's been addressed or discussed in many studies and presentations. So the PSA is probably the easiest thing we can do to get an idea as to what's going on with someone's prostate. And I mentioned to my patients that I think their PSA should be a number that they're quite familiar with. Just as if you're familiar with your blood pressure or your blood glucose, or if you're a diabetic, your hemoglobin A1C. I think a man should have a good idea of what his PSA is. You know, you might not know the exact number, but you have a general trend. Now, PSA is not a prostate cancer specific test. What PSA helps us to do is to have an idea to what's going on in the prostate. You can have a markedly elevated PSA and not have cancer. Again, you can have a prostate infection. You could have just ejaculated, which can raise the PSA. You could have ridden a bike or a motorcycle and vibrated the prostate, and any of these things can cause abnormalities in the test. So again, the PSA became available in 1994, and it's been used as a screening test for prostate cancer. Let's see here. I got out of here. Let's see, just a second. Here we go, got it right here. Very good. Thank you. I'll do that. Okay. So again, when we talk about PSA, everybody, we say a normal PSA is less than 4. Okay. Now that is not always the case. It depends on what age you are, and there's what we call age-adjusted PSAs. But in general, 0 to 2.5, I agree with that, is fairly safe. 2.4 to 2.6 to 4, you should probably speak to your urologist or your physician about it. That's one that we probably want to follow a little bit closer. If your PSA is less than 1, in many instances, you don't have to worry about it because in general, that number remains relatively stable. When you get to a PSA of 4 to 10, that is when the number is suspicious, and that definitely requires an evaluation. It doesn't necessarily mean you'll need a biopsy. Again, it doesn't mean you have prostate cancer, but an evaluation would be necessary. And a PSA above 10, by the same token, can be associated with prostate cancer, but is not always the case. So you can have a bad prostate infection, injury to the prostate, and the PSA can be quite high. So for me, and in my practice, generally a trend of the PSA is more important than an actual number. So if a gentleman runs a high PSA, and he always runs a high PSA, that is more comforting to me than someone who just has an immediate spike of an elevated PSA. So the PSA can be evaluated and taken into context. So what are the benefits and risks of screening for prostate cancer with PSA testing? So again, recently and over the past sort of decade, there have been conflicting recommendations regarding PSA screening. Is it useful? Is it not useful? Are we opening men up to overtreatment for prostate cancers that would most likely not kill them or impact them in any way? And all of those issues are relevant and important to discuss. So generally, even though we recommend screening between the ages of 45 and 70, these are still discussions that a patient has to have with their physician. You have to feel comfortable about getting a PSA test because it may lead to further and further testing. But at any point in time, just having the test doesn't mean you're committing yourself to another step and another step and another step. So I do think getting the screening is good. I think getting a number, a baseline number, and having that information is important because information is always valuable. I don't think there's bad information. Having that information is helpful. And then in consultation with your physician, you can decide where to go from there. But at the end of the day, patients in consultation with their physicians should discuss the risks and benefits of PSA screening. So as it comes to men of color, I do strongly think that we should be screened in general, particularly men of color who have a first-degree relative. That's not even an issue. If you have an uncle, brother, father who've had prostate cancer, who've dealt with that disease, then screening should be performed. And I strongly recommend having PSA screening done at an early age, even men as early as 40. Specifically, if they have that first-degree relative who was diagnosed at an early age in their 40s or 50s, you can start as early as possible. And the other thing I should mention is that as we've evolved with our detection and treatment of prostate cancer, we've got additional testing that can be done, genetic testing, complex PSA testing that can give us a better idea as to one's risk for prostate cancer going forward. So how is prostate cancer diagnosed? Okay, generally it's done with actually, prostate cancer can only be diagnosed with tissue. Okay, so you have to have a biopsy. That's the only way you can diagnose prostate cancer, confirm a diagnosis of prostate cancer. But before we get to that point, generally we will do PSA testing, and we can do additional testing, MRIs, imaging. We can do additional blood work. We can do even urine-based testing to help us decide whether a biopsy is necessary. But the only way you can diagnose prostate cancer is with the biopsy. Another thing that's been sort of debated is a digital rectal exam still needed? In my practice, yes, everybody needs a digital rectal examination. Nobody wants to do a digital rectal examination. So as much as you don't want to have one, I don't want to do one. But with that being said, it gives us important information that we can use to help diagnose prostate cancer. And it's an easy exam. Most men come in, and I've got a couple of slides, a little humor here. Most men come in and they bristle at the fact of having a prostate examination done. And I explain to them it's no picnic for me either, but it's a necessary evil. We need to find out what's going on. And I will say that in many instances, it's not even detecting prostate cancer. I've detected rectal cancers with a digital rectal examination. So it's something that should be done, and it takes just a couple of seconds, and really it's not that big a deal. The one thing I tell patients as well is that if you went to see the dentist and he didn't look in your mouth, you'd be upset, right? So if you come to see a urologist, he doesn't put a finger and check your prostate, you would probably be upset. So We just have to go through what we have to go through, and we'll get an answer as soon as possible. So if, let's say, your digital rectal exam is abnormal, or the PSA is abnormal, and it's recommended that you have a prostate biopsy, this is an image of how a prostate biopsy is done. Generally, we'll place a transrectal ultrasound probe into the bottom. The ultrasound probe is about as big as my index finger, so as big as the finger you had your examination with. And using the ultrasound probe, we'll take a total of generally 12 pieces of prostate tissue. Now, those are just generally taken throughout the prostate gland. If there is a nodule or if there's something that we can see on ultrasound, I may take additional biopsies in those areas. But in general, a 12-core biopsy is pretty standard. Now, if we get to sort of second-level testing, you can have what we call an MRI fusion biopsy, where we can have a patient have an MRI prior to a biopsy, and then at the time of the biopsy, actually use ultrasound real-time images and fuse them onto the MRI images and do a biopsy in that way, and that leads to a very precise and specific biopsy. But that's not necessary for everybody. A standard 12-core biopsy with an ultrasound is pretty routine. One thing I should mention, though, is that a biopsy should not be taken lightly. So when we discuss doing biopsies, I always like to make sure my patients are well informed about risk of biopsy. And the biggest risks are bleeding and infection. I think that some people are concerned about, will I develop erectile dysfunction or urinary incontinence from a biopsy? And that's highly, highly unlikely. But again, risks of bleeding, infection, significant infection can occur. So generally, patients will need to be off of any and all blood thinners, as well as be on antibiotics, and do an enema before biopsy is performed. So, okay, you go through a biopsy, and hopefully the biopsy is negative, and then you've had a negative prostate biopsy, which I will tell you, with a gentleman who has an elevated PSA or family history of prostate cancer, that can be some of the most exciting information that they can receive, and I've gotten hugs from men who, when I tell them their biopsy is negative. But by the same token, if, let's say, you are diagnosed with prostate cancer, the initial information we get from the biopsy is about the Gleason score grading, okay? So in this slide, you'll see we talk about Gleason's patterns. And when we discuss prostate cancer, when Dr. Gleason initially described prostate cancer, he had a score that went from basically 2 to 10, okay, where the Gleason score would be as low as 1 and go 2 to 10, or 2 to 10, sorry. Basically, cancers less than 5 are felt to be just atypical cells and not truly cancer. So now to meet the base criteria for cancer, the Gleason score is going to be a minimum of 6. And that score will go from 6 to 10. I can go into a little bit more detail, and that'll probably be something I can answer in a question. But when we talk about prostate cancer, 6s and 7s are usually felt to be pretty benign and in many instances observable. 9s and 10s are highly aggressive disease, and those need to be treated fairly aggressively as well. And 8s are sort of in the middle. So the Gleason score is very important. And then you go find out about prostate cancer staging. So in general, a lot of patients, or most patients, depending on their PSA level and the results of their biopsy, may undergo staging, either with an MRI, CT scan. There's a newer test called an Axeman scan. And these will help us to determine whether or not the cancer is still within the prostate, which would be a stage 1 tumor if it's in a small area of the prostate. If it's stage 2, it's in both sides of the prostate. Stage 3, just outside the prostate, in the local lymph nodes around the prostate. Or stage 4, that it's spread throughout the body into other areas of the body. And depending on the staging, that helps us decide how these diseases should be treated, or how this disease should be treated. So let's say that, unfortunately, you were diagnosed with prostate cancer. What are the questions that you should ask your urologist? Because generally, your urologist is the one who would give you this information. So, and I've answered some of them. You know, how aggressive is this? You know, ask specifically, what is the Gleason score? Because Gleason score is universal when we discuss prostate cancer. So a patient may say it was not very aggressive, it was highly aggressive. I always say, do you remember what the Gleason score was? Because if you tell me 6, that gives me a picture. If you tell me 10, that gives me another picture. So the Gleason score is important to know. How high was your PSA at the time of diagnosis? Because again, that helps us to understand at what stage was the cancer identified. How aggressive is the disease? Does it look like the cancer is just inside the prostate, or has it spread? And specifically, if it has spread, where is it spread to? Is it still around my prostate gland? Is it in my pelvis? Has it gone to my bones? Because those are important questions to ask. And what other tests do I need before we decide on treatment? And I will tell you that now there are a handful of tests that we can offer to help us decide how to proceed with treatment, or even active surveillance, which is a form of observation. So then you can say, well, what are my options for treatment? And can we discuss treatment options? And we'll go into the individual treatment options as we go forward. But when you ask about treatment options, you should specifically ask, how will this affect me? Doctor, do you think I need this form of treatment? Can we watch this? If I do have treatment, what happens if this doesn't work? What are the side effects of this treatment? Because again, when you ask these questions, it helps prepare you mentally and physically for what will be going on down the road. And I think as an individual, it's important, it's incumbent upon me as your urologist to have you have a good understanding of what you're choosing to have done, okay? Because prostate cancer specifically, as opposed to some other cancers, is not a one-size-fits-all. Prostate cancer treatment can be individualized, although there are some sort of basic tenets that we do need to follow. And one thing that I strongly recommend is that if you have any questions, always consider a second opinion. Most physicians, if they feel comfortable and confident in their diagnosis and treatment, will have no problem with you recommending a second opinion. And don't be afraid about insulting them or affecting their ego, because if it does cause them to be insulted, that's probably not the doctor you want to deal with. Okay, so we talk about, prostate cancer types and treatments. What should we do? At this point in time, you've gotten the diagnosis. You're like, okay, doc, I've got to deal with this prostate cancer. How should I deal with it? And then it becomes sort of my job to give you information, right? I give you information. I explain to you what we have available, and then the patient and the doctor will come up with a plan. So you have to decide who's going to help manage your prostate cancer. In general, it is still a urologist, okay? Urologists are well-trained to manage prostate cancer, even at significant degrees of prostate cancer. In general, I manage prostate cancer from beginning to end. In some instances, if a patient wants, we do get medical oncology involved, an oncologist, and it's not unreasonable to have an oncologist also be informed of your disease, and if you have an oncologist that you trust. But feel comfortable that if you have a urologic oncologist or a urologist who deals with prostate cancer, it's very reasonable to have them manage you from beginning to wherever the disease process takes us. So early stage prostate cancer, what can be done? I have many men in my practice who we just follow. Now, the one thing I explain to everybody is do nothing is not an option. So let's say a gentleman gets diagnosed with prostate cancer. He says, well, doc, I don't want to do anything. Do nothing is not an option. Okay, that doesn't work. But do we have to recommend surgery or radiation or hormonal therapy? No. We can observe the prostate cancer, and that's what we term active surveillance. And that's where a patient will come in routinely, get their prostate checked, get their blood tests done, and we can proceed. But do nothing, again, is not an option. And depending on where we go from sort of low-grade disease, low-stage disease, to more aggressive disease, you find that there are more options for treatment. One distinction I like to make is there's what's known as castrate-sensitive prostate cancer and castrate-resistant prostate cancer. Now, when we talk about that sort of prostate cancer, generally that's prostate cancer that has already spread. It's become metastatic or it's become locally advanced. And when we talk about those types of prostate cancer, they can be manipulated by manipulating a gentleman's testosterone levels, and we'll discuss that in a little while. And only about 9% of men, when they're diagnosed with prostate cancer, will have metastatic disease. And that is very much dependent upon the fact or has changed with the advent of widely available PSA screening. So again, when we talk about what can we do for early stage prostate cancer, active surveillance is something I recommend. I do it quite commonly. And a patient will come in and get checked routinely. And what I explain to the patients, we'll continue doing this until I have to pull the trigger, and I'll let you know when we have to pull a trigger. And what I mean by that is generally PSA changes. I feel something different on a digital rectal examination. Generally, when you do active surveillance, you're committing yourself to a repeat biopsy in about 2 years. And if the repeat biopsy shows a progression of the disease, either in the amount or in the appearance of the cancer cells, we may go ahead and recommend treatment at that time. But active surveillance is very reasonable. Sometimes I find patients who go home and they speak to their family and they get an answer, "What do you mean Dr. Anglade didn't want to do anything? He didn't want to give you radiation. He didn't want to have you to have surgery." And I explain to the patients that many men can live with their prostate cancer. They don't need it treated immediately. And we'd like to spare you from some of the side effects that immediate treatment can cause. So active surveillance, again, for the right type of cancers makes a lot of sense. So let's say you have prostate cancer, and active surveillance is not an option, either due to the type of cancer, the degree of cancer, the volume of cancer. I may recommend surgery. And as a urologic surgeon, and that's something that I have no problem recommending. And that's where the prostate is removed surgically. Okay, and nowadays prostate cancer is done with a surgical robot. When I initially trained and finished my training, we were doing open prostatectomies, and in many instances that is no longer a surgery that's performed. With the surgical robot, which I also was trained to do, the visualization is much better. The ability to use that surgical robot to perform precise dissection, control bleeding, and also preserve some of the nerves that are important for erectile function as well as urinary continence, the surgery has improved by leaps and bounds. Or if surgery is not appropriate for whatever reason, then radiation is actually very reasonable. We have external beam radiation, where radiation is shot into the prostate from outside the body. There's what we call brachytherapy, and that's where we implant radioactive seeds in the prostate. And sometimes when the seeds are implanted, you still will get an external radiation boost, so that's sort of a combination therapy. There's also something called proton beam therapy, which is a type of external radiation. So radiation continues to improve, and that's a very reasonable treatment for sort of locally advanced prostate cancer. So again, when we talk about then and now, before the advent of PSA screening, before the advent of some of these newer technologies, men were found to have metastatic prostate cancer at the time of diagnosis. So again, in my earlier slide, I said 9% of men are diagnosed with sort of advanced disease. In the past, it was as high as 70% of men would present with back pain and bony metastasis. And at that point in time, prostate cancer was truly a killer. Now we're finding it early, and we're able to treat it earlier. Risky surgeries, not that the open prostatectomy was a risky operation, but again, it was not as technologically advanced as the robotic surgery is currently. And one size fits all. As we continue to go forward and genetic testing becomes more a part of the diagnosis of treatment of prostate cancer, we're finding that our treatments are more individualized. So this is a slide that shows the Da Vinci system. So some patients would ask, well, Dr. Anglade, will you be even in the room when I do the surgery, or are you going to use this robot? And it's sort of a misnomer. The robot is an assistant, essentially. So the surgeon will sit in the console and control the robot, but by the patient's bedside, there will either be a surgical assist or a second surgeon and help to guide the robot and help with the surgery itself. But again, with the technology, with the visualization afforded by the robot, the surgeries become much better. Radiation therapy, as I described earlier, we can put seeds into the prostate gland, as denoted on the left side here, or you can have external beam or a combination of both. And then we get to the point where we start to discuss side effects of these treatments. The biggest side effect for surgery, or the two biggest side effects of surgery, are erectile dysfunction and incontinence. And now patients sometimes say, well, Dr. Anglade, I have my prostate and I no longer produce an ejaculate. Is that a side effect? And I say, well, no, that's not a side effect. That's an expected consequence of removing the prostate gland, because one of the biggest functions of the prostate gland is to produce your ejaculate. So if you have a prostatectomy, you should know that you will no longer produce an ejaculate. And for men who are interested in having more children or having families, you may want to consider banking sperm prior to a prostatectomy. So those are considerations that you have to have. Erectile dysfunction is a common problem after prostate surgery. For many men, that is their biggest hesitancy to want to have prostate surgery or even having the diagnosis made. I beg to differ, and I argue that incontinence is actually the worst. Incontinence is something that men have to deal with. If, let's say, God forbid, you were incontinent after an operation or after radiation, that's something you would deal with every day, all day, wearing pads or undergarments or what have you. Whereas erectile dysfunction is generally something that you just deal with from time to time and can be addressed. So, again, that is where the surgical robot has become very valuable because incontinence rates are decreasing. And so if you're able to control your urine as a gentleman or as a urologist who specializes in erectile dysfunction, I feel very comfortable and get your erections back to a point where you can feel comfortable that you have addressed your prostate cancer and you still function sexually. As far as pain, that can occur, but usually that's self-limited. I mean, most people don't have long-standing prostate pain or pain after their surgery, but that can occur. Depression and fatigue, those are more associated with sort of the hormonal treatments that we use for prostate cancer. So when we talk about advanced prostate cancer, and again, this is prostate cancer that has left the prostate gland, or highly aggressive prostate cancer at the time of diagnosis, we may recommend hormone therapy up front, and I'll explain a little bit more about what that is. It's sort of a misnomer. We don't give you hormones. What we try to do is use medicines to decrease your testosterone levels, and I'll explain why that's important. And some of the newer treatments include immunotherapy, where we can sensitize your body's immune system to fight cancer, and that is not just for prostate cancer. Immunotherapy is being used for many different cancers. Bladder cancer we use it for in urology, kidney cancer. So immunotherapy is very important, having a strong immune system to fight the cancer itself. And chemotherapy. Now, chemotherapy is generally reserved for sort of really advanced prostate cancers when these cancers become resistant to other forms of treatment. So speaking about hormonal therapy, as I explained, there are hormones that are released by the pituitary gland, which is in your head, which sends signals to your testicles to produce your testosterone. Okay, and that testosterone is what feeds prostate cancer cells. So when I have discussions with patients, I explain that testosterone is sort of like fertilizer to prostate cancer cells, or it's nourishment to prostate cancer cells. So when we can shut down your production of testosterone, we can starve those prostate cancer cells. So there are many medications we can give to men to stop the production of testosterone. In the past, we used to castrate men for this purpose and remove their testicles, and that still can be done, but most men don't want to lose their testicles, so they'd rather take a shot, which is fine. But they get a shot usually every month or every 2 to 3 months, and that decreases their testosterone production. And in many instances, that's all we need to do, because as the testosterone becomes castrate, the PSA levels will come down. Now, doing this sort of treatment can have other sort of side effects. It can cause bone loss, bone weakening, so we have to be mindful of that. But it also causes fatigue. But in general, most men tolerate it well. It also may cause hot flashes, and sort of a male menopause by decreasing the testosterone levels. But in general, most men tolerate it well. The other thing I will mention is that even though we can shut down production of testosterone from the testicles themselves, there are small amounts that are made in other glands of the body. So we may need to add secondary medications or oral pills to block that testosterone from making it to the cancer cells. And then here's a slide that speaks a little bit about immunotherapy. At this point, there's really only one FDA-approved treatment for immunotherapy for prostate cancer, and it's called Provenge. And that is a situation in which we will take blood from the individual. These white blood cells will be sensitized to prostate cancer components, and then these cells will be reinfused back into the patient. And Provenge has been shown to show a survival benefit in the sense that you have your own body's immune system fighting the prostate cancer. So, as we're getting closer to the end of the discussion, I like to talk a little bit about what's generally the natural progression of this disease, okay? You find somebody with an elevated PSA, the patient will be found to have prostate cancer, and if they're able to, they may have either active surveillance, which is observation, or a local therapy. Now, I spoke about surgery and radiation, but I would be remiss not to mention there are other treatments available as well. There's what we call thermal therapies, something called HIFU, which is high-intensity focused ultrasound, where ultrasound can be used to heat up the prostate cancer cells and essentially kill them. There's cryotherapy, where the prostate can be frozen to kill the cancer cells. So there are newer treatments that are always evolving. So local therapy is not a good option, okay? Then we get to hormonal therapy. And first-line hormonal therapy is decreasing the testicles production of testosterone with injections. Okay, and so let's say we do that, and then we start developing, again, castrate-resistant prostate cancer, cells that are not sensitive to starving them for testosterone. Then we can use these second-line therapies where any testosterone that is still built within the body or produced within the body can't get into those prostate cancer cells, so we starve them even more. And so that doesn't work, or if we find that that is starting to work, we may also add immunotherapy on top of that to really get a robust response and try to get the cancer under control. One thing I will mention about immunotherapy is that it's not a therapy we want to wait to use if somebody is ill or becoming more weakened by their prostate cancer, because we want a robust immune system to be able to fight the cancer cells. And so then once you get past immunotherapy, you start talking about chemotherapy and additional treatments that are available at that point. So again, we talk about side effects because any sort of treatment for prostate cancer may have side effects. And they're listed here, but I think I've discussed them already. Probably one of the bigger side effects, again, in most men, they're concerned about erectile dysfunction, and any and all of these treatments can cause that. Some people think that by having radiation, they'll avoid that side effect, but that's not the case. And the other thing I will mention is that a lot of men who deal with prostate cancer in their 60s and 70s, and we know that most men in their 60s and 70s, the vast majority of them will already have erectile dysfunction, regardless of treatment for prostate cancer. So this slide is a newer one that I use because this slide contains a lot of the newer tests that are available for prostate cancer. So the days of a PSA and a digital rectal exam and that being it are pretty much gone. I think some urologists still practice that way, but let it be known that there are different tests that we can order. Some genetic tests, different types of PSA. There's a test called the 4K score that I order routinely that looks at additional proteins than the PSA to help me decide whether or not this elevation is due to aggressive cancer versus just maybe BPH. There's a test called an Oncotype DX test where when somebody has a prostate cancer that's diagnosed, we can send it to the lab where they run genetics on the actual prostate cancer cells and see whether or not the appearance of the cells underneath the microscope is similar to what they're finding based on the cell's genetics, so that's very important. Once the prostate has been removed, there are additional tests, a Polaris test, a Decipher, where we can look again at the cells and the DNA of the cancer and see whether or not we feel it's going to be more aggressive or not. And something that's become more and more available to us is just genetic testing. In the female breast space and some of the GYN malignancies, they've been checking for BRCA genes and so forth for many, many years and identifying them with aggressiveness of different tumors. And we're starting to see some of that technology coming into the prostate cancer space. So again, I think the future is bright for the treatment and diagnosis of prostate cancer. So, and to that end, one thing I will mention is that we are getting better at treating cancer in general, regardless of financial situation or race. And you can see, particularly in this prostate cancer slide, over the past decade or so, that men poor affluent counties, black, white, we're doing a better job with prostate cancer in general. Okay, so this is also what I think is most important, something I always like to share with patients. I think doctors, particularly doctors in Western medicine, get a bad rap for just treating diseases with cancer and surgery and chemotherapy and so forth. But we always talk about healthy living and diet and so forth. So one thing I explain to patients when they ask, well, what can I do, Dr. Anglade? I think you've told me I have cancer and I want to pursue active surveillance. What can I do to help keep this cancer sort of in a manageable state? And everything that you see listed, if you smoke, don't smoke. If you drink a lot, decrease the amount of alcohol you consume. Be physically active. Eat more fruits, vegetables are very important. Cut back on animal protein. Increase plant-based protein. Cut back on red meat. So all of these things are important, and keep up with your doctor because, again, if you are being evaluated for prostate cancer or for cancer in general, it's important that you keep up with your physician, follow your physician's recommendation for follow-up. Keep your physician's phone number nearby, because if you have questions, call and ask questions. If you're not getting appropriate answers, seek out a second opinion. But it's important that you and your physician become partners in the management of your disease. It's not really fair to expect the physician to take care of everything. There has to be ownership on both parts, and that's the way you end up with best outcomes. So another thing I strongly recommend, speak to people in groups such as these. Take advantage of this Northside group and speak to people who've been through the disease, who've gotten to the other side, who can give you counsel as to what they feel that they went through and how they would have done things differently. Because, again, as somebody who's entering his, fifth decade of life, I luckily have not had to deal with prostate cancer, but I know a lot of men who have, and who it's in their family tree and they're concerned about it. So I always recommend you speak to people who've dealt with the disease, because that can definitely help as you go through this prostate, or if you have to go through a prostate cancer journey. So in conclusion, and we're finally in conclusion, what I'd like to say is that screening with PSA and DRE can save lives, so don't be afraid of a digital rectal exam. Again, as a man of color, as a man who's in his 50s, I get mine done every year and have been doing so for the past decade. And I actually will say I feel more comfortable knowing that I have been checked and thoroughly evaluated than wondering whether or not there's something else that can be done. African American men and men with a family history are at higher risk of prostate cancer and should talk to their doctor about screening. I think that any man who has a family history of the disease should be screened and should be screened annually. I think if you have a first-degree relative who's had the disease, particularly if you're a man of color, you're doing yourself a disservice if you aren't checked routinely. Talk to your family. Let your family members know. If you're a man who has prostate cancer, let your brother know, let your father know, let your sons know, so that they can be appropriately screened. And information is always good. So the more information you know, if you know what your PSA is, if you know how to manage your prostate or your prostate cancer, it's very important and can only lead to better outcomes. So I think with that, I'm going to conclude. I hope you enjoyed our discussion today. If you have any questions or concerns, please feel free to ask any questions now, and I'll entertain them. And in general, I'll put in a little plug for Northside Hospital and their Cancer Institute, and for Georgia Urology. We're the biggest practice here in the Southeast, and there are doctors all throughout the Atlanta metro area. Please feel free to seek us out for any urological issues you may have. So with that being said, Dr. Gore, I'm going to turn things over to you. I appreciate you giving me the opportunity to speak to your audience, and I thank you for all that you do.
Dr. Anglade, that was absolutely amazing. I was over here taking screenshots and like, oh my God, this is good. This is good. I need to share this, because I have, quite a few men in my practice as well, even though I take care of breast cancer. Thank you so much for everything you do. And before we jump into the questions, I do want to remind everybody that Northside Hospital Cancer Institute has a plethora of resources that you can access even if you are not plugged into the system as a patient. Number one, we continue to offer cancer screenings, including free skin screenings, as well as prostate cancer screenings. Also, if you go to the website, you can get a full list of dates, times, and how to go about scheduling these free screenings. Furthermore, the genetics program is absolutely amazing. And if you have any questions or concerns related to your personal risk and your family risk, I implore you to use this resource. And then if we go to the next slide, you'll see information about cancer support community, who continues to offer so many resources for our patients. Number one, they also have a monthly prostate cancer support group. Secondly, there are so many classes, yoga, tai chi, all of these different things that you can utilize for your mental wellness as well as you go about your cancer journey. Also, we have dietitians, oncology dietitians, specifically, and nutritionists and cooking classes. And so these are some of the resources we have. Go to cscatlanta.org for more information. And also a quick plug for our other facilitators. The presentations on gynecological cancers as well as colorectal cancers are up now on the CSC website. So if you missed those prior presentations, please go to the website and look at those. And with that said, we're about to jump into some questions. We had a lot of questions popping off from the chat box while you were presenting, Dr.
All right, I hope they're not too hard, but I'm ready for them.
No, these people came ready today. So
all right. Well, I'm here.
Our participants wanted clarification regarding when to start screening. Is that 55, okay, 45, or 40?
Again, that's an excellent question, and that's a question that I wrestle with, okay? I think that if you have no family history and have no issues, okay, you're urinating fine, no family history, just to really get a screening, 55 is appropriate, even for men of color, to be honest. But actually, let me take that back. I think 50 would be appropriate even for men of color in particular. 55, I think maybe a little bit late, but I'd recommend 50. However, if you have a first-degree relative, right, you know, your uncle, your dad had it, what have you, I'm a big proponent of 45. And if you have a first-degree relative who had prostate cancer diagnosed early, you know, your father had prostate cancer diagnosed when he was 48 or whatever, or you have an uncle who died of prostate cancer in his 50s, I almost want to say it's never too early to be screened, but honestly, I'd say about 40 years of age at that point in time. Get a PSA, know what that PSA number is. You know, I can't stress how much better somebody feels that in that situation, you do a PSA and a PSA is less than 1. You say, oh, PSA is less than 1, prostate exam is normal. You're good. You know, come back in a year or two, we'll keep an eye on it. And I believe that gives a lot of comfort for many of my patients. So if I didn't answer it, I'd say 40 if you've got really bad disease, 45 if you've just got a first-degree relative, 50 if you have no symptoms or complaints.
And another question we received, how much emphasis should be placed on the digital rectal examination for community screenings?
For community screening, I've been at community screenings in the past, and actually to find a place where you can do digital rectal exams is difficult, right? So if you're at the local VFW or what have you, the hall, it's hard to find a place where people can do digital rectal exams. If we had the ability to do digital rectal exams, you know, it might sound crazy for me to say this, I think it's absolutely necessary. All things being equal, you should have an exam at the time of a PSA test. But if that's not feasible, right, then I think the PSA test is a good way to start. But I don't ever discount a digital exam. And so if you're not getting one, if your primary care doctor doesn't want to do them, request a urological consultation. Nobody likes to do them, so don't get that, you know, confused, right? Nobody wants to do it, but it's necessary.
Mm-hmm. And speaking of the PSA test, how often should these men be getting this? This is something that we do every year, correct?
Correct. It's an annual exam. Now, if the PSA is elevated, I may increase that frequency, okay? If somebody has an elevated PSA or a PSA that's rising, I may say a year's too long. I want to see it again in 6 months, okay? So it all depends. But in general, annually a PSA is fine. If your initial PSA is very low, okay, let's say your PSA is less than 1, 0.5, there are some studies that would suggest checking it every 2 years. But in general, annually is appropriate.
Good. Question. How often have you seen a normal PSA level in a patient, specifically, our Black men with a
Mm.
prostate cancer diagnosis?
Uh, No, that's a great question, excellent question. I would say if the PSA is less than maybe one, it's highly unlikely, okay? But I have found prostate cancer in men with PSAs of threes and fours. So for case in point, let's say, your PSA was 2.5 one year. You come back the next year, it's 3.2. And then by 6 months later, it's 3.4 or 5. That's a normal PSA. It's less than 4. If you go and look at a reference range on a lab test, it'll say normal, but that guy has cancer until proven otherwise because the velocity of the PSA is changing significantly. So that's something that needs to be evaluated. And you might not pick that up on a digital rectal exam. You may. So again, PSA velocity in that instance is very important.
That's good. That's good. Thank you. So let's
Mm-hmm.
see. We have so many good questions on this board today.
Okay.
This next question says, can Dr. Anglade share his thoughts on Resume, specifically with its viability in patients with BPH?
Okay, great question. Okay, now, so since we're talking prostate cancer, but somebody wants to ask about Resume, so I'll tell them about that specifically. Resume is a technology where it's a minimally invasive treatment for an enlarged prostate. And what essentially happens is through a telescope placed in the penis, we can deploy a needle that goes into the prostate and puts basically water vapor, hot water vapor into the prostate. And over time, it can kill some of the BPH cells, the benign cells, and cause the prostate to shrink. Personally, it's not something that I really do in my practice, although I have partners of mine who think it's a great technology. I think it can work. I've had patients who've been satisfied with it, but I do think it's important to have preoperative evaluation to make sure it's an appropriate test. And what I mean by that is to make sure that your prostate is truly obstructing. I think a cystoscopy should be performed where a urologist will place a scope through the prostate and in the bladder and make sure the prostate looks good for that type of procedure. But it is FDA approved and some men do well with it. But again, it's not something that I do a lot in my practice.
And this next question, I'm going to figure out the right way to word this. It seems that the
Mm-hmm.
question is asking specifically, is there a correlation between the number of cores on prostate biopsy and the acceleration of disease? This patient is currently on active surveillance and had a negative MRI a year ago. So
Mm-hmm.
is there correlation, I guess 6 out of 12 cores with
Yeah.
cancer versus 0 or 1 core with
Right.
cancer?
4 out of 12.
Yeah.
Yeah, that's very important. Yeah, it's very important how many cores are positive, okay? Because when we do a standard 12-core prostate biopsy, and again, it's sort of a standard biopsy, we identify 12 areas of the prostate to take tissue from. If you have 1 core that's positive versus 11 cores that are positive, and let's say for argument's sake, they're all Gleason 6, that low-grade disease, you still have a huge volume of tumor, and that's important. The other thing I didn't mention is when we generally do the prostate biopsy, the pathologist will say how much of that core is involved with cancer. So I've done prostate biopsies where somebody will have Gleason 6 disease and, let's say, 2 out of 12 cores, each core less than 50%. Right? And say, okay, that's not a lot of cancer. I feel comfortable watching this guy. Some of these other tests make sense. But if you find somebody has even 2 cores, same number of cores positive, but each core is 100%, that's a different sort of disease process. So to answer that question, it is important to know how many cores are positive because that may change the way we look at the disease. Knowing the amount of cancer in these cores is also very important. But having a negative MRI is great. I love having a negative MRI. But just a week ago, I was reading an article about how a negative MRI should not preclude a repeat biopsy. Okay, so even though the MRI is negative, having a repeat biopsy does make sense. And so you shouldn't have sort of a concern or, sort of a distrust in your urologist if he says, look, your biopsy is negative, but I still think you need a biopsy. I'm sorry, your MRI is negative, you still need a biopsy. That still is what we are recommended that we do.
That's an excellent question. Thank you to the person that asked that question. Next question. With fewer men participating in clinical trials, do we know if African American men respond to precision medicine as well as their white counterparts?
That's an excellent question. And then honestly, the answer is yes and no, right? I hedge, right? Yes and no. There are some new sort of precision-based technologies that are doing the studies that show that African American men may do better. So one I mentioned is Provenge immunotherapy. It shows that it is actually quite effective in men of color. Oncotype DX, I think, did a study where they were able to see that men of color are also benefited by the testing. So in general, we're finding more and more of these studies being done. I think that when these studies are done, we can find out if it's better or worse for us. But I encourage, my counterparts to participate, and particularly if it doesn't require anything. If you just have to let them study your biopsy specimens, you already took it, or do some blood work. I mean, I think it's helpful to give that information.
So in that same vein, the next question is, any thoughts on how to remove barriers for African American men to participate in more clinical trials?
You just be available. I think that a lot of urologists in the community probably don't participate in a lot of trials, but if you're asked to participate, I think it's helpful to do so. I think a lot of university-based physicians still like to do clinical trials, or they have their residents and students do those, so that's important. But it just has to be available. I mean, there are studies that are being done, which is encouraging. There are studies that are being done, and I think that a lot of treatments for prostate cancer and the manufacturers of these treatments, it makes financial sense for them to find ones that work well in African American men because they know we're more adversely affected by this disease, right? So if you can find something that definitively has a better benefit for men of color, that would be better for you, right, as a manufacturer of a disease treatment process, right? So they are interested in getting that information. So the other thing I should suggest is, let's say, for whatever reason, you're on, you did Provenge, or you're on Firmagon for your prostate cancer. I'm sure you went to the Firmagon website and looked it up, and you say studies for Firmagon. You can find them. They're out there. And some of them will also give you a little honorarium to participate. So I think it's, we just have to be proactive and want to participate and look at some of those studies.
Absolutely. Absolutely. Thank you to the person that asked that question. Next question. Yeah. I underwent seed implant combined with hormone therapy. My PSA started increasing again and cancer was found in my lymph nodes. How common is this recurrence?
So seed implant plus hormonal therapy?
Yes.
And then it's actually, it depends. I mean, off the top of my head, can I cite a recurrence statistic? I don't know the situation. I don't know at what point in time the cancer was found. Like if it's Gleason 9 disease and you had that same treatment, it's different than if you had Gleason 6 disease. But we all know cancers can recur. In general, what I found is that nowadays, if the recurrence is still localized, like let's say it's still in a lymph node in one side of the pelvis, or it's somewhere where that it can be addressed, there's no reason to not consider additional radiation to that area and still achieve cure. So case in point, given that question, let's say you image that individual and find that the recurrence is still fairly localized, you can still radiate that area. Maybe it was missed with the initial radiation field, but if you haven't radiated that area, you can still radiate it, and I've done that numerous times and achieved cure. So I think it's it's something that should be discussed with your urologist or with the radiation oncologist who did your original radiation. There may be room for more.
Thank you. We've kind of gone through this. The question was how many samples are generally taken during a biopsy. I think it's fair to say 10 to 12. I know that's
correct.
So for that poster, that's the answer to that question. Next
well,
question.
let me throw one thing in there. So, like, let's say you had a negative biopsy, and PSA continues to rise. Your urologist may recommend a saturation biopsy, is the term we use, and in that case, you could have 20, 25 cores of prostate tissue taken. And that's a different type of biopsy, so that can occur, but the standard initial biopsy is about 12 cores.
Okay.
12 to, 14 cores, something like that.
Thank you. Next question. I knew we would get a question like this to pop up because it's a huge concern. With the prostatectomy that causes a loss of the prostate, does it also result in complete loss of erections?
No, not necessarily. You can have what's considered a nerve-sparing prostatectomy. So let's say the cancer is relatively localized and you have a surgeon who does I would suggest it can be done with an open operation, but now with the robotic surgery, it seems to be a little bit more precise. You can have the prostate removed to preserve the nerves that are necessary for erectile function. But the other thing I always like to mention is removing your prostate is not going to improve your erections. So you have a lot of guys who say, I'm 55 years old, my erections aren't that great. Okay, I took out my prostate, now my erections are a little worse. Yes, that will most likely happen, right? But if you have very good erections prior to having your prostate removed, there's a very good likelihood that you can still have good erections, but removing your prostate doesn't improve them. It'll probably make them a little worse. But with that being said, if you're cured of your prostate disease and you can hold your urine, which is very important, we've got very good treatments for erectile dysfunction.
And I think one of the last questions we have, do you find prostate cancer to be more aggressive in African American men? And if so, is active surveillance still a safe approach?
Yes. Now, active surveillance, I don't think has to be, is not a race-related sort of issue. I think if the cancer genetics are appropriate, you can do active surveillance for anybody. Now, again, this goes back to the whole discussion of taking ownership of your disease and taking ownership of your active surveillance, right? You don't say, okay, I'm going to do active surveillance, doc. I'll be back in 3 months, but don't come back in a year and a half and be surprised if the cancer is spread, right? So if you come every 3 months, you get your prostate exam. Now, granted, that's not the guarantee. It can't get worse, but when you have that sort of relationship in general, active surveillance, I think, is a very good option. I have young guys I recommend active surveillance to. So let's say I have a gentleman who's relatively young, the cancer is very small. I may tell them, look, I feel pretty comfortable at some point in time we're going to have to do something about this disease, right? But if you've got, 6 months or a year, you're trying to start a family, you got this or that you need to do, I think we can watch it safely for a little while. And I think that's very reasonable.
I think that is all for the questions. Again, Dr. Anglade, this has been absolutely amazing. I've learned so much, and I know that all of our participants did as well. So thank you for, giving us your time and all of your expertise on this matter. Again, guys, go to Northside Hospital Cancer Institute website and Cancer Support Community website for additional resources. And with that being said, I'm going to turn it back over to Katie Armsby with Cancer Support Community.
May I interrupt just 1 second and just thank you, Dr. Gore, and thank everybody at the Cancer Support Community at Northside for giving me the opportunity to speak to your audience. It's been a pleasure, and hopefully you'll have me back again sometime soon.
Oh, you stuck with us now. We're just totally going to.
Thank you. Thank you both so much for being so generous with your time and expertise with us this afternoon. As we wrap up, I will invite Dr. Anglade. Do you have any closing remarks you'd like to share with us?
Yeah, again, I think this is a very important topic. I'm glad to have had the opportunity to discuss it today. As I said, Prostate Cancer Awareness Month was in September. We've got Men's Health Awareness Month in November. So if you're a man or have men in your lives, please encourage them to take care of their health, exercise, eat better, and see their physician. So again, thank you very much, and please seek us out. Just 2 words: Georgia Urology is always available for urologic needs and care. Thank you.
Thank you. And Dr. Gore, any final thoughts you'd like to share?
No, I'm usually always running my mouth, but I actually don't have any final thoughts today. But thank you, everybody, for participating. Again, my sincerest gratitude to Dr. Anglade as well for being with us today. And join us again next week where we will be talking about breast cancer, and I'll be doing that presentation. Dr. Anglade's presentation, this redo of this should be up soon, and also the ones for gyne-onc and colorectal cancer are also up on the Cancer Support Community website. Thank you for joining us.
Absolutely. Thank you. Like Dr. Gore said, please join us next week. Same time, same Zoom place with Dr. Gore and Dr. Janine Pettiford.
And like Dr. Gore said as well, for previously recorded programs and the 2 other programs in this series, feel free to visit us at cscatlanta.org. Thank you everyone for being here today, and everyone have a good weekend. Take care.
Bye, everyone.
Bye. Thank you.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.